Just to do a quick intro. So, good afternoon, everyone. We're really pleased to have here Deirdre James. Deirdre is an endocrinologist in internal medicine doctor. She is at University of Tennessee Health Sciences Center. So she's also the program director for the endocrine fellowship and is the assistant dean in the College of Medicine of student academic affairs. So she's been active in clinical research in both pharmaceutical studies and also in NIH funded projects. She's been um, working in studies analyzing the pathobiology of prediabetes in a biracial cohort that's called the POP ABC, and also on the PROP ABC cohort studies. So it's a great pleasure to have you here with us. We invited Deirdre. She's also serving as our key contact, our key lead at the University of Tennessee. We have a regional core that is part of the Georgia Center for Diabetes Translation Research. That includes University of Miami, the James Center for Health Research, University of Florida, and University of Tennessee. So we're really happy to have you here. Today, Deirdre is going to talk about transitions of care services for high-risk patients with diabetes, closing racial disparities to improve morbidity and mortality. Thank you, Deirdre.
Thank you so much for that wonderful introduction, and thank you all for inviting me to give this talk today. And so I don't have any financial conflicts of interest, so I definitely want to describe that. And so the objectives today will be to discuss the diabetes epidemic and also to review some recent literatures on the transitions of care. So just to kind of get everybody up to speed about some of the numbers, the most recent CDC data shows 37.3 million people in the US have diabetes. That's about 11.3% of the adult population. Only 1.6 out of the 37.3 have type 1, so all the others have type 2. And so unfortunately, 8.5 million of these people are undiagnosed. That's about 23% of the adults. And so with diabetes. And so what that means is if you don't know you have it, you can't control those blood sugars and you're at risk for complications, of course. 96 million people, adult Americans, about 38% of the population have prediabetes. And we all know that prediabetes is a call to action. It's just not one of those benign things that we just say, oh, well, we'll have to, monitor it. And its prevalent increases with age. So if you're older than or at 55 years of age, it's about 26.4 million people, which is about 48.8% of the population. In Tennessee, we're doing a little bit worse. We're in the obesity belt. So about 650,000 people in Tennessee have diagnosed diabetes. So about 12.7% of the adult population. An additional almost 160,000 people are undiagnosed, and about 1.8 million people in Tennessee have prediabetes. So every year, almost 40,000 people in Tennessee are diagnosed with diabetes. Diabetes is very costly. $327 billion is the total cost for people with diagnosed diabetes in 2017. They actually increased about 33% from the preceding 5 years. These expenses were thought to be mostly related to hospitalizations and medications used to treat complications. They incur about $16,000 annually, almost $17,000 annually. And the annual expenditures were about 2.3 times higher than in a person without diabetes. And so we mentioned that most of this was because of hospitalization. So we really have to mitigate readmissions. So in 2018, almost 4 million people had a 30-day all-cause mortality hospital readmission. That's about 14%, so of all causes. And almost 30% of this was avoidable, completely avoidable cause. Mostly it is thought to be suboptimal care transitions that increase the risk of post-discharge adverse drug events and lead to Increased risk of hospitalizations. Medication-related problems are estimated to be the largest cause. And so we all have, seen the data from the Hospital Readmission Reduction Program, the CMS, the Centers for um, Medicare and Medicaid Services. And they don't necessarily look at diabetes. They look at acute myocardial infarction, COPD, heart failure, pneumonia, coronary artery bypass grafting, and hip replacements or total knee arthroplasties. But unfortunately, diabetes is not amongst one of the things that they look at. And so the Joint Commission actually puts out information about what they feel is the foundation of good transition of care. First, you need wonderful leadership, early identification of those who are at most risk, thorough psychosocial assessment, a multidisciplinary team that's involved, patient and family engagement, especially in our elderly patients. Medication management, of course, as I mentioned before, that can be the largest cause of readmission, and good transfer information, especially when they're transferring to another facility. If I talk to my friends from the community who work at some of the long-term care facilities, sometimes the patients will arrive with pretty much a discharge MAR, but no information about what happened, even after a lengthy hospital stay. And so we all are well aware that the prevalence in the US of diabetes has an ethnic disparity. And so we see our Black, non-Hispanic, and our Hispanic population, as well as our American Indian and Alaskan Natives being disproportionately affected. And so we know that because our patients are being, our patients of color are being disproportionately affected, there are no hard and fast data about um, racial disparities in actual hospital admissions nationwide, but we can definitely look at some of the data that we have about readmissions. And so here is a study, a pilot study from the VA in Cincinnati. It's the diabetes transition care from the inpatient to outpatient. And this is mainly a VA population. So they looked at the 30-day all-cause readmission rates. And these particular patients had an A1C greater than 9, so they were very poorly controlled. They use mid-levels to help with their diabetes transition program. So there were adult nurse practitioners, was the primary care coordinator, and then they would make calls 24 to 48 hours after discharge, and then weekly until the patient met with his or her primary care provider. An in-hospital assessment was done to improve an evidence-based care plan. The telephone visits by the advanced nurse practitioner was coupled with face-to-face visits in the endocrine clinic for an average of a 2 to 3 month post-discharge. They had access to a 24/7 nurse hotline on the weekends and evenings if they had any problems with their sugars or had any medication questions. There was a continuity of medical care between the hospital and primary care provider was facilitated through this nurse practitioner with even sharing of the documentation, which is a little bit easier when we're thinking about the CPR system that's in most VAs. Throughout, there was attention, careful attention given throughout on the patient's needs, including the reason for the primary hospitalization, as well as the comorbidity and risk. There was effective engagement with the family members and care providers with an emphasis on education and support. They really honed in on this because they felt as though, which is true, patients could not take care of themselves if they weren't well aware about what was going on with their health. They focused on early detection and response to healthcare risks and symptoms to obtain longer-term positive outcomes, and escape adverse events that affect hospital readmissions. And then the communication included the patient, the family, caregivers, and providers, as all part of one team. And so if we look at the patient care outcomes, the hospitalization rates, excuse me, let me just move the cursor so I can see. So the hospital rehospitalization rates after discharge, and you can see that it was 40 people enrolled in the program, was approximately 10. And so it was, well, 10 patients, and approximately 15% this was compared to approximately 15% of patients overall. And so it really was not statistically significant. However, there are some theories that we'll talk about soon after. As far as the post-intervention, we can see that the post-intervention A1C actually went down quite a bit, 2 points. And so that definitely tells us that, this intervention definitely worked. And then even in our insulin naive patients, it actually went down even more. So they actually had more benefit when it comes to the patient outcomes. However, this patient population definitely did not mirror my own here in Memphis, Tennessee. I work at the Safety Net Hospital. And so it was, as you can see, mostly male patients, 87.5% of them were male, and they were mostly non-person of people of color. So about 80% were all white. And so that's definitely not usually what we see here at Regional 1. And so let's transition a little bit and talk about this study that was done here at Temple. And so this was a randomized controlled trial. Of course, it was not blinded, but basically in this study, what they did is they had an intervention group and a usual care group. As far as their intervention group, they had, in addition to what was considered usual care, they had patient-centered education. They had an A1C based adjustment on their diabetes therapy that was actually done by an endocrinologist. And they had post-discharge support, which basically included a 1 to 3 day post-discharge phone call. They also had a call every week for about 4 weeks. And then everyone had a referral for a nurse visit in order for the nurse to come out to their home and look at their medications and to make sure that the medications were firstly present and that they were taking them appropriately. And so this patient population definitely mirrored our own a lot more closely. Sorry, I just have to move this. Sorry, I'm trying to move them. Zoom thing so I can see. Okay, so as you can see, the income less than $12,000 approximately was pretty large portion of their population. So the most of them were below the poverty level, and we can see that most of them were African American in this population. There were very few that were employed, and most of them had A1Cs that were uncontrolled. And so, and if we look at the top here, is basically all of their patients. So they were looking at everybody, all of their patients who had diabetes. And so if we kind of look at the subgroup with a baseline A1C that was greater than goal, so greater than 7, we can see that they actually did not find a significant change. So it didn't meet statistical or really clinical significance for their change in the A1C. However, if we look at the readmissions, we can actually see that the readmission rate was much lower in the patients who actually received the intervention compared to the usual care. And then if we look at the cost to intervention, so the patients who had the intervention actually used, their cost was about 21% less overall. And if we look at even the ones who had controlled diabetes, so their A1C was not above 7, it was 33% less than the patients who received usual care. And so they also had much less episodes of hypoglycemia, which could was as high as 11% in the population in their hospital. So it really begs the question, even if some things are not necessarily statistically significant, they will be clinically significant and you can make a difference. And sometimes it's beyond just the A1C numbers. Sometimes it's the readmission rates. Sometimes it's the cost of the hospitalization. And so you will always see that there is benefit when we transition. And so because of this, here at Regional 1, we thought that we needed to start our own initiative. And so Regional 1 overall, for you all who aren't as familiar, is a 350-bed acute care community teaching hospital. So we have medical students and residents. It's mainly, they have primary care centers here and within the community, embedded within the community. And there are multiple subspecialties here. So we have just about them all, including endocrinology, as you already know. And then we have our high-risk OB, and then the endocrinologists support them as well, especially for the diabetic patients and the thyroid patients. And also we have a level 1 trauma center here. And so we thought, let's see how we can incorporate clinical pharmacists within the roles of transitions of care. And so, and mainly this is because we are short-staffed here, and so we could not, unfortunately, have multiple endocrinologists and multiple providers helping. However, we definitely saw an area where our clinical pharmacists could really help. And so the interventions were performed by the clinical pharmacists, and it's been shown that they reduce hospital readmissions and medication errors and increase patient satisfaction because the patients feel as though it's multiple providers and they feel more that it's a patient-centered care home. And so there are multiple aspects that lead to this improvement in the transitions of care. You have the comprehensive medical management, medicine reconciliation, medication and self-management education, medication acquisitions assistant, and the follow-up visit or call. Or call. And so this was a prospective quality improvement initiative. Our second year postgraduate ambulatory care pharmacy resident kind of did most of the patient interactions along with the other clinical pharmacists and the physicians overseeing. The service included 3 points of contact. So prior to hospital discharge was the first, within 72 hours of discharge, and there was outpatient collaboration with the internist and endocrinologist. And we also had the postgraduate ambulatory residents in our endocrine and internal medicine clinics, like they were there every week. And so just to kind of give you an overview of this service, we gave the patients an overall overview, an introduction while they were still here. And then we actually had the pharmacist bring the medications to the bed. And so what we would notice is we would discharge a patient on a certain medication regimen, and then for whatever reason, they couldn't afford it. and they would either not get their medicines at all, or they would go back to whatever regimen they had before they were hospitalized. We gave them a transition of care packet, and that had adherence tools, a booklet to write their blood sugars in, and then we had follow-up, which I'll talk more about the follow-up in the subsequent slides. And then, of course, we would document every encounter and provide communication with the providers as well as the patients. There was a phone call within 72 hours of discharge, and then there was an ambulatory visit within 7 to 14 days of discharge, usually multidisciplinary, continuity of care, and then they were given a patient satisfaction survey afterward. And so they to be included in the study, they either had to be affected with type 1 or type 2 with the A1C greater than or equal to 9, which is similar to that VA study that I mentioned before. And then they had to have one or more of the following criteria. So they had to be discharged on insulin, had to have a admission for hyperglycemic emergency, whether it was DKA or HHS, admission for an infection related to uncontrolled diabetes, or an acute exacerbation of heart failure. Exclusion criteria is if they were discharged to a long-term care facility, just because those patients usually cannot get back within 7 days. And then, or if they left against medical advice, if they use an outside pharmacy or primary care provider. Unfortunately, we usually cannot access the community primary care physicians to ensure a hospital follow-up within 7 days. So that was a barrier there. If there was cognitive impairment requiring a caregiver assistance, that was one of our exclusion criteria. And if they had an uncontrolled psychiatric illness. And so our primary outcomes was the rate of unplanned 30-day all-cause hospital readmissions and emergency room visits as well. Secondary outcomes was the completion rate of the post-discharge follow-up phone call within 72 hours, which all of our patients did. Completion rate of the post-discharge ambulatory care visit within 14 days. Pharmacist interventions and patient satisfaction, because most hospital systems are really pushing for HCAHPS, for good HCAHPS scores. And so overall, we ended up with 12 patients over the rough 19 months. They review daily the patients that were admitted under our 4 internal medicine teams and assess them for the inclusion/exclusion criteria. However, we were only able to enroll 12 patients for the study. As you can see, about the ones who had both diabetes with A1C greater than or equal to 9 and heart failure were only 2. If they were just had heart failure exacerbation, was 2 patients, but the ones who just had diabetes without heart failure were about 8 of the patients. You'll notice half of them were female. They were slightly younger than the patient population that we saw a moment ago with the Temple study, but all of them were African American. And then you can see with the payer source, much like Temple, very few of them had commercial insurance, and mainly they were uninsured or self-pay. When we think about the patients with the diabetes and the reason for admission and things like that, we could see, almost half of them came in for a hyperglycemic emergency. And then only one of them had some type of infectious complication. And I mentioned before about the heart failure, and mainly type 2 diabetes as well. And so when we think about patients who the 4 patients who did have an acute exacerbation of heart failure, one of them was newly diagnosed, so did not have a prior diagnosis. All of them had a reduced ejection fraction, and then and 3 out of the 4, so 75% of them had 1 or more previous heart failure related hospitalization or ED visit in the last 12 months. And when we think about the all-cause readmissions of the 3 patients who were readmitted, 1 was for syncope, 1 was an ED visit for hyperglycemia, and 1 unfortunately ended up having osteomyelitis. And so we can see that almost all of them completed their post-discharge phone call within 72 hours. Almost all of them completed their post-discharge ambulatory care visit within the 14 days. There were 38 pharmacist interventions. So when we say pharmacist interventions, meaning changes of medications, things like that. The number of patients that were satisfied with the pharmacy transition of services, all of them. So they were 100% satisfied. And about 75% of them were interviewed on admission as well as at the end. And then only 50% of them were able to get education prior to discharge. And that was because some of them discharged on weekends when our clinical pharmacists were not necessarily available. And we just had our outpatient pharmacists there. So as far as the discussion here for our pilot program, which was really small, 3 of the 12 patients were either readmitted to the hospital or visited the emergency room within 30 days of discharge. And when we think about some of these hospital rates, even from the CMS data, and once again, CMS usually does not include diabetes and things like that. But if you look at around the country, individual hospital systems normally will report their data. For the poorly controlled diabetic, it can be as high as 30%. Post-discharge follow-up phone call and ambulatory visits were completed for almost all patients. There was high rates of patient satisfaction with the service, and there was a standardization for data collection for our pharmacist intervention. Now, we did have quite a bit of limitations, had a small sample size. Not many of our patients were willing to commit to the program. It was non-standardized medication reconciliation process. Multidisciplinary communication regarding discharge may have been a little bit obscured, especially when they discharged over the weekend. And then some of the demographic data was either missing or incorrect. And so overall, we do think that this pilot program was successfully implemented, and we were actually able to convince our hospital staff that it was so important that we're about to roll out an official transition of care clinic that will be staffed by our, not by the residents, of course, that will rotate through, but they have hired a clinical pharmacist who specializes in ambulatory care to help our patients on a much larger scale. The formal process can improve transitions, and then the transition of care service may increase cost savings and reimbursement, which we'll talk about momentarily. We saw with our temple study that the cost savings for our patients with the highest A1Cs they used about 21% less than the patients without the intervention, and 33% less compared to the usual care group. The multidisciplinary approach will definitely lead to improved outcomes. And so as I kind of alluded to, a few moments ago, the next step in the future directions is expansion of our services here. Once again, we're the safety net hospital in the city. So if our patients do not receive care here, they're more likely not to receive care anywhere. And we do have a large indigent patient population, mainly people of color, African American and Hispanic. It will be 7 days a week, and we'll try to bolster our patient enrollment. We also did not have a formal referral system in the electronic medical records. We would just kind of scour the 4 inpatient internal medicine team to try to find patients who we felt as though would benefit. Well, that will change a little bit. We will definitely scour those lists as well, but we'll also talk to the providers about actually sending a formal referral for patients that we may miss. And then we're going to implement processes to improve the medication reconciliation on admission and discharge. And I think, and I'm not sure if your hospital systems are like this, but one of the reasons why our medication reconciliation process is so strange is that if we send a new prescription down to our pharmacy, and I'm not sure why this is, it's really a quality improvement issue. If our pharmacists and pharmacy techs don't look very closely, if they just see, especially if the patient already has a prescription for that particular medication, whether or not the dosage changed, they may not necessarily look at. If that patient has refills on their current prescription, they'll profile the new prescription, even though the indication in the dosage may have changed. And so that was a major issue. So some of these patients were basically continuing therapy from on medications that they were on before they even came. It was a major issue. One of the reasons why we were able to convince the hospital that this was so important is that whenever we think about transitions of care, the CMS, the Centers for Medicare and Medicaid Services, will reimburse $180 per patient if they're seen within 14 days of discharge, if they're in a transitional care program. And so once again, we talked about those 6 topics that did not necessarily include diabetes. However, a lot of our patients with diabetes have other comorbidities that are included within those 6. So that's the estimated total cost for conducting group visits is about $700 per month. So relatively low. It's not going to cost our hospital much at all. And then the estimated revenue is between $2,100 and $3,600 per month. So basically, it can make our hospital money, because at the end of the day, I am well aware that our hospital, is usually in the red. And a lot of times if there's an intervention, they won't let us, they won't really give us the green flag unless we can kind of see, let the powers to be see that they're actually going to at least break even, if not make a little bit of profit from it. The transition care program will generate hopefully about $2.70 to $4.50 per dollar spent in the program. And so the estimated revenue is only based on a group size of 6 to 10 patients. And so where that becomes significant for us is that we were only able to enroll the 12 patients. So even if once it is available hospital-wide, if we were not able to recruit that many, our hospital will still see some revenue. So in summary, addressing transitional care is an important quality of care marker. Different transitions of care models have been identified, utilized, and evaluated. More research should be aimed at establishing a standardized translation of care guidelines because we need them, especially in our patients who are most affected. And so usually those are people of color. Thank you very much. I really just want to acknowledge our Department of Endocrinology, Diabetes and Metabolism, and our clinical pharmacists, Garraway Anderson, Jennifer Campbell, and Drew Armstrong. Any questions?
Thank you very much, Deirdre, for that overview. Maybe I can start with a question now, but it's open to anyone. Please, either in the chat or please just raise your hand, jump in at any time. One of the I guess the things that is not very clear is that many of these patients with diabetes that come admitted for hyperglycemic emergencies of hypoglycemia, they get readmitted, but most of the time is not for another diabetes emergency episode. As you said in your patients, one had a hyperglycemia, one had I think osmolysis, and the other one had a syncope, right? So many times they come back from other reasons. So one of the questions here is the diabetes education part, is it that important? What is it that you think is that one of the key parts that helps patient stay at home healthier? One of my, just to follow up on that, I don't know, I'm just thinking about the ways that a patient can navigate the health system. Does literacy matter? How do you know, how can you get in touch with the system? How can you solve the problems? I didn't get my medication. I don't have a phone number to call. Nobody answers the call. So the thing, has anybody looked into that, or what are your thoughts?
So I absolutely agree when it comes to, we need to figure out what keeps them at home. And so the readmission rates, the studies show that usually it's a medication related problem that brings them back to the hospital. So the reason why they're readmitted. And so whether it's they don't have their medication or they take it improperly or things like that is the reason why many of them are readmitted. Now, when we try to figure out how our patients will remedy that problem, I think the Cincinnati VA had a wonderful idea where they had that nurse practitioner available basically 24/7, and a person manning those phones who they could talk to. Now, in our hospital system, absolutely, because I was even on call this weekend. Anytime someone needs either a refill or has a medication issue, they can definitely call, and the physician on call will answer the phone. But sometimes our patients, and they tell me, by the time they get through 20 different prompts and they've been on hold for 30 minutes, they usually just hang up because they get discouraged. It's just not a phone line that one number and they can get through or leave a message. And so I think that is a big issue. And so if we had someone who was going to get in touch with them within those first 72 hours, or as in the Temple study where they called every week. So even if something didn't come up this week and it happened next week, we can actually keep those patients out of the hospital.
Yeah, and that makes a lot of sense. I think it's like reaching out to the patients. And I think that the study by Dan Rubin didn't show any benefits in glycemic control, as you will expect. Both sides dropped about a point in A1C, as you will expect. Most patients get better after the hospital stay, but it sounds like it's that component of reaching out, especially to the most vulnerable. Anyone else? Any other questions?
So, Deirdre, this is Guillermo Pierres. Thank you for presenting. So why are you limiting insulin treated with hemoglobin A1C greater than 9 if the primary outcome is I don't know if that's the primary outcome, but I believe there was a readmission in patients with heart failure. I mean, they don't look to go together to me. I mean, if you want to prevent readmission or hypoglycemia, then you take insulin treated patients with fully controlled diabetes. But if heart failure, maybe the intervention should be open to everybody with diabetes, not just insulin treated with hemoglobin A1C greater than 9. I'm just wondering.
Correct. So one of the reasons why is especially in our pilot study, is we had to limit it because it had to be feasible for the limited space and the capacity for our clinical pharmacists. They weren't given any more salary support or any the clinical pharmacist wasn't necessarily, our student wasn't given any extra time. And so what that means is, on top of all of their other duties, they actually had this project going on as well. And so you're absolutely right. So now that we're trying to expand this hospital-wide, we definitely will include a more broad patient population. Thank you very much for that comment.
Yeah, and the second one is that, I was in the mentoring team for Dan Rubin's K23. That's the study that he just published. And the main problem that I see with this kind of studies is that the K23 ran out. He just got another one in a different area. So how to implement that if you don't have support for pharmacies, for endos, for whoever is going to follow those patients? It's a big challenge. I mean, I do appreciate the effort. I mean, this is great. I mean, I was just wondering, a place like Grady that is very similar to the Met,
Absolutely.
how can we implement this kind of program without a grant support?
Absolutely. And I think that's the great challenge when we think about safety net hospitals. And, even though and I guess it's my level of training and my altruism. I went to Meharry Medical College for medical school. And so it's pretty much just like the Med, as you mentioned, Regional 1, a very poor patient population. So that population is very near and dear to my heart. And so I treat my patients as far as their medical conditions, and I don't look at insurances, and I don't look at the business aspect of things. And so when we are presenting different interventions and things to the hospital administrators, even though they definitely want to help the patients, they're worried about their bottom line as well. And so I do think, sometimes we have to search and hunt and try to help administration see the actual monetary value in these things. And so if we can get a mid-level or a pharmacist to kind of make some of these connections, and maybe just have the providers support them instead of being dedicated, I think that may actually help as well, because some of the hospitals, they're just worried about numbers. How many patients are you seeing in clinic? Not necessarily, and how much you're billing in clinic, not necessarily about the transition of care piece.
Anyone else?
All about
Any other
arguing.
question? Before, I don't know if anyone has any other comments. I was wondering if anyone has used technology to help connect the patients to the health system. Like with Epic is widely used. I don't know if you guys have Epic, and the use of MyChart and maybe helping patients understand and navigate a little bit of the system, make sure they know when they have the appointment, get contacted for those appointments. I know that it's been used for other health conditions. And that's something that
The
you guys
Temple
have thought
University.
about.
I'm sorry, go ahead.
Yeah, I don't know if anyone else has used that, like incorporating that as well, like trying to use, because we've surveyed our patients, and 90 to 100% of patients have smartphones, and they have Wi-Fi access at home, most of them. So I think people is now connected. The problem is that the digital health and the ecosystem is not expanding. So people sometimes don't know how to use them. Sometimes my patients have like this incredible computers at their hands, and they don't know how to use a text. They don't know how to use the different apps. So there's a lot of kind of technology literacy as well. But I think there's an opportunity to help them navigate the health system by learning to use these tools.
Absolutely. The EPIC system is actually what Temple used in that study, if you all get a chance to read the full study. And it definitely helped them. We don't have Epic here at Regional 1. There is a Baptist hospital here that does use Epic for patient reminders and things like that. Not only for patient reminders, however, we do have within our system the capability of a patient portal where if you're savvy enough, you can go on and actually message your physician. And usually it will come to your inbox within 24 hours if they have a patient care question.
Hi, Mega.
Hey, hi, Deirdre. This is a great talk. My name is Mega. I'm actually a primary care physician here at Emory, and I do a lot of work in kind of diabetes management as well. One, I'm very impressed that you were able to get buy-in from your health system to implement a program like this. So I'd love to hear a little bit more about that and how you engaged with your, decision makers in that process. But my second question is, one of the things that you mentioned, kind of thinking about the cost piece of this, was that, the CMS kind of 7 and 14-day transition of care visit reimbursement, which, that I don't know. At Emory, it seems like there's been no sort of standardized way that we've done a good job of implementing that. But a lot of that relies on the communication between the inpatient team and the outpatient team to try and get that appointment set up and make sure that that patient makes it to that follow-up appointment, and then that the outpatient provider has all the information that they need to have a successful visit. I would say in my practice, 9 times out of 10, that doesn't happen for a variety of reasons, right? There's fragmentation of care. So they're admitted at a hospital outside of the Emory system where we don't have access to the records. Or maybe they were admitted. Maybe we do have access to the records, but there's incomplete records. And so we have a patient there with a medical, like the med list, and then no discharge summary. We don't actually know what happened at the time of the visit, right? So there's all these breakdowns of communication that we can go on and on about. And so I'm curious if you could talk a little bit about kind of how you guys thought through that piece of the transition of care, because the reality is, I imagine, as you mentioned, and during the pandemic, right now, if my patient needs to see an endocrinologist, it might be 6 months, right? And so a lot of this has to fall on primary care. And so I'm curious about how you guys thought through that piece of the communication and just broader about what your thoughts are about how we engage primary care to address sort of these transitions of care issues. That's a lot of questions.
So you're absolutely right. Oh, no, it's okay. So you're absolutely right. And so, that was one of the reasons why we excluded in the initial, pilot study, we kind of excluded those who had other primary care, who sought care, their primary care, other places, because we could not guarantee those quick follow-up visits. Now, whenever we think about getting them into our clinics here, we actually have a post-discharge follow-up clinic, and we have had that for quite a while. However, it kind of served as the post-discharge / employee health clinic. And so it was, for the longest time, it was just mainly a provider providing care to our hospital employees, especially during COVID times. Now, because of that communication, that breakdown in communication. And so what would happen on the inpatient side, if a patient needed discharge follow, even in the post-discharge clinic, they would send a referral. Well, unfortunately, those referrals sometimes didn't get looked at for days to weeks. And so unless, like you said, for that reimbursement, unless it's that strict, they actually got a phone call and was seen within those, 14 days, then you don't get reimbursed for it. And so there was a ton of breakdown. And so what was helpful was that, those 3 people, our pharmacists, who would basically bird eye every patient and actually make sure that they move through the process accordingly. And once again, we don't have a real good system to remind patients of their appointments. But since those particular pharmacists, were responsible for those patients, they would make sure that they had a really tight calendar and would call those patients even multiple times to remind them of their appointment. Now, outside of that, which, hopefully we get a much broader patient population, as I mentioned, and get more patients enrolled once we, are successfully able to implement it hospital-wide. However, I'm not necessarily sure that we will have the capacity to do that for everyone now. And so just like Dr. Umperez, perfectly mentioned, why was it so low? Why did you only have these amount of patients? Well, that's all we could handle at the time. So it makes me wonder, will we get some of these same results? Because we can't hold our patient's hand as closely as we would like through this process once it is on a much larger scale. So unfortunately, I don't have any really good answers for you, but please let's stay in contact. So within the next 6 months to year, as we have, waded through this whole process hospital-wide, I hope to have more answers for you, since this was a small program here. Did I get all of the questions? Did I hit on all the topics?
Well, I was going to ask one more follow-up, and can you talk about kind of this engagement with your health system, like did this and how they've kind of bought into this concept and said, okay, we're gonna fund you to do like the program? Like, was that from the beginning, or how did you kind of approach that, and how did that happen?
Not at all. It's all about the numbers. And so we actually showed them the data as far as, kind of that last slide, how much revenue will you actually make compared to what is spent. And so whenever we do pilot programs at Regional 1, it's almost like you have to get a pilot program that's going to cost them nothing, because otherwise they're not going to support it, because we just don't have the funds. And so, but once we were able to show, hey, these are our results, this is what the potential revenue is, now we started to get more buy-in. And so one of their biggest questions was, well, this pilot program had such few patients. And then we could say, well, hey, this data is for, even if you just have 6 to 8 patients, you can still make this amount of money. And so that's the only reason that we were able to get that type of buy-in. And also we have a university foundation as well. And so sometimes for things that we can't necessarily pay, like the hospital can't pay for, we can write a small grant to the university foundation, and they can actually pay for it. And it really helps because we have employees, we have community, and even, I'm not sure if any of you all shop on like Amazon or use Amazon Smile, like those, and you can pick an organization. Then Regional 1 Foundation is there as well. And so people donate by a multitude of ways. And so say, for instance, if you need a new ultrasound machine and that's just not in the budget, in the GI lab, then you could just write a grant, and if it's approved, you can get a new one.
Just to remind and everyone in the region, there's pilots from the center, and specifically that can go outside of the center. That could be usually, you just need to add some technology component that I think it's very easy to use in this kind of thing. It can be dashboards, can be texting, can be wearables, can be anything. That a little bit of small pilot money sometimes can help move these pilot projects forward. Also, that's something to keep in mind. So I think we're gonna end there. Thank you very much again, Deirdre, for your time, and I'm glad that new lines of communication are starting. Hopefully, there can be more